Welcome to today's webinar on Action Against AMR, Charting India's Path to a Sustainable Future, organized by Voice of Healthcare and supported by Thermo Fisher Scientific. Antimicrobial resistance, AMR, poses a significant global threat to health, agriculture, and sustainable development. As India advances its National AMR Action Plan, fostering multi stakeholder collaboration is essential to establish a sustainable, inclusive approach aligned with global standards, ensuring effective action against AMR and safeguarding future health and development outcomes. We are honored to welcome esteemed experts who bring a wealth of diverse experiences and perspective. Our speakers for today's session are Dr. Tikesh Bisen, Public Health Specialist, Surveillance, AMR, PATH India. Welcome, Dr. Tikesh. Dr. Jyoti Joshi, Senior Science Advisor, International Center for Antimicrobial Resistance Solution. Welcome, Dr. Jyoti.
Hello and namaskar.
Dr. Rajeshwari Sinha, Program Manager, Sustainable Food Systems Program, Center for Science and Environment. Welcome, Dr. Rajeshwari.
Hello, everyone.
Dr. Vasant C. Nagvekar, Director, Infectious Diseases, Sir HN Reliance Foundation Hospital. Welcome, Dr. Vasant.
Yeah, good evening. Hi, thank you so much for the invite.
So I'm Dr. Manisha Khurana, and on behalf of Voice of Healthcare, I thank you all for being here. So to begin with, my first question would be to Dr. Vasant. Why is the reduction of antimicrobial resistance, AMR, critical in improving patient outcomes in clinical settings?
So definitely, I think the way presently India is going through a gram-negative resistance, where almost nosocomial infections to the tune of 60 to 70% would be carbapenem-resistant organisms, and so the clinical outcome would definitely be guarded because we have hardly any antibiotics to treat this gram-negative, and especially the pseudomonas, multi-drug resistant pseudomonas, where and the multi-drug resistant acinetobacter, where we have hardly any medications except colistin to be as a single drug to be used. So I think antimicrobial resistance and decreasing it by various whatever possible mechanisms, I think is the key to the present solution of tackling the antimicrobial resistance. Maybe whether it's antimicrobial stewardship or whether it is the most important would be, I think I would stress upon the diagnostic parts to reduce the AMR. So I think we are facing every day this problem about hardly we don't have to scratch our brains to decide about what antibiotic to be given because we are left out with nothing except for polymyxin based therapies. So I think it's a real challenge, and we really require to fight against this antimicrobial resistance. What's there, and more in nosocomial, we don't have so much problem in the community. So India has more problem with gram negatives, whereas the Western world is more of gram positives, and like the VRE and the MRSA is a more problem with the Western world. In India, we don't have so much problem about MRSA. Hospital-acquired MRSA is hardly seen. So and even VRE is not so much common as the Western world. But our problem is gram negatives uh, and the antimicrobial treatment reserve, which is hardly anything for the gram negatives, and it's a big challenge. And I think we definitely require to look at it and really tackle this situation, which is just going out of our hands at the earliest.
Right. So, since the implementation of National AMR Action Plan is there, I would ask Dr. Tikesh, what have been the most notable successes of India's National AMR Action Plan since its launch in 2017?
Thank you, Dr. Manisha, for bringing this up. So, post 2017 National Action Plan for Containment of AMR has launched. So, I would like to emphasize here when Global Action Plan for Containment of AMR has launched. So, it has only 5 strategic area, but when India has adopted NAPCAR, so that time sixth strategic priority area collaboration has been added. And soon after this, India is selected and announced as a contributor for GLASS network. It's a global AMR surveillance network. And after that, in 2021, there is a letter plotted from the Secretary Health related to that, for bringing the governance mechanism at the national level for intersectoral coordination committee, technical advisory group, core working group. Also, antimicrobial stewardship program has been launched. So at the hospital level, at the secondary or tertiary hospital level, at least healthcare practitioners follow stewardship related to rational use of antibiotic. Also, small policy frameworks, supportive policy framework, which are aligned with the One Health approach. So, for example, sale of cholesterol prohibited for food producing animals in 2019. 19 antimicrobials banned in food productions. Also, tolerance limit for antimicrobials, for 43 antimicrobials has been in animal products has been set in. Addition to that, under PSA, Principal Scientific Advisor Division, India AMR Innovation Hub has been established. Uh, and considering environmental aspect, National Institute for Cholera and Enteric Disease produce a report on environmental AMR priorities also. Addition to that, we have identified which are the priority pathogens, so which will help our policymaker as well as implementer to take appropriate action, appropriate measures also. An important aspect is in alignment with the national action plan. Till date, total 7 state has prepared and launched their state action plan. Again, this is in alignment with national action plan, and as per my limited understanding, there is Rajasthan and Karnataka has already drafted and it's under finalization for a state action plan. Related to awareness generation, so it's PPP, public-private partnership also taken place. Their NCDC has also launched. There are videos, posters, even other developmental partners are also contributing to it. And this is not only limited to the hospital, but it is going to the grassroots level also. The involvement of my frontline health worker is also there. This is the sensitization of healthcare providers as part of WOW. So again, this is the we can termed as a success of NAPCOR also, because one of the strategic priority areas, if we talk about the first strategic priority, it's awareness generation. So this is again, and this is not only restricted to the human health, but other animal health and other departments also contributing and supporting to it. So it will be not only related to human health, but in other sectors also the awareness is getting generated. Last year, National Leprosy AMR Surveillance Guideline also released. So again, we are not only focusing about the one aspect, but there are other diseases and other infectious diseases where AMR can play an important role, and containment strategy will be valued. So efforts is taking in that direction as well. So this is
Right.
yeah.
Right. You have summarized it well, and I think we have achieved so much, and there is so much to be achieved. My next question would be to Dr. Jyoti. What are the key financial, resource challenges obstructing the effective implementation of AMR strategies?
Thank you, Dr. Manisha. I would like to first thank the organizers for inviting me to this discussion. So I think the one big challenge we must step back and realize is antibiotics get used everywhere, whether they are in community, in the hospitals, like Dr. Vasant was telling, or by people in even outside the health sector, which Dr. Tikesh has talked about. And these antibiotics unfortunately get used like even just as nutrition supplements, if I can say, in India. If your cold doesn't get improved in 2-3 days, the first person to take one antibiotic is the patient himself, so that he or she doesn't have to take off from the day or look after the other work. So the challenge with AMR is it is invisible. The damage that taking an antibiotic without the need for it, without a diagnosis, is not visible to any of us, because antibiotic resistance genes can get transferred from our normal to from our pathogens to our commensals, and to vertically as well as horizontally. So what happens is the areas where we have to act is not clear, whether it is the community or is it the hospital. The burden is immense, though the typology might differ. Like Dr. Vasant was explaining, the hospitals have a different flora and level of infection compared to the primary healthcare system in the health sector, but they also have a burden. Similarly, antibiotics are used not just for human health, so for animals. So, animal care and the food that we eat also affects us. So addressing AMR efforts requires resources that are, first of all, designed in a way that they can tackle antimicrobial resistance in each of these sectors, whether human health, animal health, or even the food and plant sector that we eat. And then the plans that we make are adequately resourced, whether in terms of finances or in terms of human resources, because any mitigation plan has to be led by very thorough evidence and research. A large part of the problem is sometimes the burden of AMR is unclear in terms of which sector to prioritize first, and each sector is thus trying to do the best within themselves. At ICARS, which is the International Center of AMR Solutions that I'm representing today, what we use, the framework is called implementation research. That means we try and partner with governments and researchers in countries to design solutions that can work for one small problem at a time, pilot them, and if they work, we scale them up at levels that the government would like to take it forward through guidelines. So the challenges are definitely, one, financial resources, but the other big challenge is systems and health resources, because there is a shortage of health professionals overall in India. Also, not just in the human health sector, in the animal sector, whether we talk of paravets. So we have a huge population of paravets. We have informal providers who are not qualified to give medicines that are of allopathic origin, but who are the only source of healthcare for people in remote areas. So making sure that we have all partners involved in a manner that is agreeable to all is the other big challenge in terms of finding solutions. The government has been coming out with guidelines to work with different sectors, but this is an area, I think, which also falls in the gray zone, and a lot needs still to be done. Thank you.
My next question is to Dr. Rajeshwari. How can India ensure compliance with existing guidelines for antibiotic use in food producing animals and agricultural products?
Okay, thank you, Dr. Manisha. So I think by now, of the last three speakers that we heard, what is very clear is that the contributors to AMR issue are multiple, and also the challenges and limitations from each sectors are also multiple. So when it comes to compliance to existing guidelines in food animal production, I would say that there are a couple of guidelines and some laws, some advisories that we have at this point of time. And if I have to summarize them very broadly, some of them are talking about judicious or responsible use. Some of them are talking about restricting certain antibiotics, and some of them are giving guidelines on when to use what, which kind of antibiotics can be used when. This is the broad categories in which we can bucket them. But when it comes to compliance, and given that we are a big country with a lot of smallholder farmer population, and a lot of food depending on their livelihood, and also coming from the ground, I think we need to take a step back and insist on something that does not even need us to use antibiotics in the first place. So what I'm coming to is that we would like to stress on the importance of going for prevention. Compliance can come, but if you are able to reduce the need and dependence on antibiotics, if you are able to avert infections in the first place, I think that is something given the situation we are in, given the kind of resources and the kind of support systems that we have from a low and middle income country like India, prevention works best. And at the same time, what in prevention, I would like to stress on factors like particularly in the food animal production settings, I'd like to talk about biosecurity, having the right kind of biosecurity in place, having the right kind of alternatives in place. There are alternatives, there are very good examples of alternatives to antibiotics working, but have we been able to dig out where what is working and scale them up and incentivize farmers to pick them so that they don't go for the antibiotics straight away? Having the right systems in place, having the right housing systems, and most importantly, having correcting the stocking density issue when it comes to industrial farming practices that we have. So there are a lot of parameters that can be corrected, taken a step back and corrected in itself when it comes to growing dependence on antibiotics in food animal production settings. And going forward, this can contribute to compliance in the guidelines. We do have guidelines, but it's not very easy to come up with guidelines and saying, okay, now there is a guideline, now let's implement and now let's have compliance. So there is something we need to rethink and reinvent the processes. I'd like to stop there. Yeah.
Sure. So my next question is for Dr. Vasant. What are the clinical implications of AMR on the management of multi-drug resistance infection in hospitalized patients?
I think in my the previous question when I answered, I did mention about the challenges of not having the antimicrobial pipeline for managing these gram-negative organisms in India. So the four major gram-negatives what we have issues are the Klebsiella, E. coli, Acinetobacter, and the Pseudomonas. So this is the carbapenem-resistant organisms, and also other organisms which are because of breakthrough, because of overuse of cholesterol. So I think the major challenge in management of clinical management of these patients is the hardly availability of any drugs and the mortality of these patients going very high. As I said, some of the and major another major concern is the infection control practices. I think if you have a good infection control practices in the ICU, you can definitely reduce the antimicrobial resistance to a large extent. And also, if you have some as Dr. Rajesh mentioned about antibiotic policies, and I think if you have strict antibiotic policies in the hospital, restricted use of high-end antibiotics, okay, and restricting them to use not for meaning allow them to use for 24, 48 hours, but beyond that to have a justification of why they are using this high-end antibiotic. I think putting a stop to all this will be very, very important. But as of now, the challenge in clinical management of all these patients is hardly having any drugs to be to hand. And so I think because of the fear of resistance, what the clinicians are doing is they are from the beginning only using high-end antibiotics, thinking that it will be more ceftriaxone resistant or a BLBL resistant, and they straight away jump to big guns like meropenem. Sometimes I've seen people using in first 24 hours when the patient is coming from community even colistin and polymyxin B. So I think this usage of high-end antibiotics is a major clinical issue rather, which is contributing to antimicrobial resistance. And I think this is somewhere where we require to we require to take complete control on this situation. So that so I think from clinical angle we are struggling every day. Every patient in the ICUs is a major challenge because we are dealing only with some of the other carbapenem resistant organisms. Anything specific you wanted, Dr. Anisha?
Yeah, I think that answers that, resistance is prevailing and we should have the antibiotics stewardship in the hospitals well in place. My next question is for Dr. Tikesh, that how well has been the One Health approach been implemented in the National Action Plan AMR across human, animal, and environmental health sectors?
So thank you, Dr. Manisha. So in my previous means when I mentioned about the NAPCAR successes, So I hope do mention about there is an intersectoral committee, means the governance mechanism in place. So whenever, because One Health is a very complex approach, not only human health, but there are other departments. And when we need to bring intersectoral coordination, other department on place, so first of all, governance mechanism has to be in place. So at the national level, there are three committees: intersectoral coordination committee, led by Secretary Health, and other line department secretaries are the part of that intersectoral coordination committee. And this is again specifically for governance and policy level decision. Second is technical advisory group. Again, the technical advisory group is specifically the technical person from all the department, led by DGHS, jointly led by DGHS and ICMR. And then there is a third is core working group. So core working group is an actual group which will work based on the guidance of technical advisory group and policy makers. So this core working group, again, these are the nodal officers of respective department, those who are working at the on AMR. Same is replicated at the state level also. This governance mechanism at the state, which ensure that this different department will come together and have exchange of information, exchange of dialogues. If a second related to the surveillance, so there are three major surveillance network in the country, like NARSnet, operated by NCDC, ICMR surveillance network, and third is NFAR network. So Dr. Jyoti is here, so from ICAR. So ICAR is also implementing NFAR network. So these are the network which are capturing information, AMR surveillance related data from respective department. Addition to that, we are all aware about the IHIP, Integrated Health Information Platform. So it's led by IDSP division of NCDC. So there are also communication is happening. So how there will be the exchange of information from human health side to the animal sector, and vice versa. Addition to that, there are some initiatives which taken by National Pollution Control Board. So it related to the they have initiated a pilot project to monitor antimicrobial residues in effluents from pharmaceutical industries, hospitals, and even the animal farms. Also, antimicrobial uses. So, Department of Animal Husbandry and Dairy is has taken a step to regulate veterinary antimicrobials, including the withdrawal of colistin as a growth promoter from livestock. And recently, post COVID, this One Health approach has take a big boom, realizing that this zoonotic diseases and other aspects. So it has provided a push to AMR also. And now we can see that each state, there is a meeting at the state level, even at the district level. District zoonotic committee is there. Previously, in district zoonotic committee, there is a discussion related to zoonotic disease only. But now, slowly, with the help of advocacy efforts, the discussion related to AMR related aspects also. So the implementation of One Health related aspect is already initiated, but long way to go, because still there are the challenges which we need to address. Thank you.
Right. So my next question is for Dr. Jyoti. To what extent has public awareness and community engagement been prioritized under the Combating AMR plans?
Thanks, Dr. Manisha. Before I clarify, maybe before I answer this, can I give a clarification? Dr. Tikesh mentioned that I'm from ICARS, but I'm from ICARS, which is Denmark based, and not the Indian Animal Husbandry Organization. So just to clear that misconception, sorry. So coming back, knowledge and awareness for antimicrobial resistance are critical, and that's why I'm glad today we are having a talk on Facebook Live through your organization on antimicrobial resistance. Like I said, infections are invisible. When the patient is in the hospital, he or she doesn't bother what caused the problem that he or she landed in the hospital with. Or when the animal is sick, the farmer doesn't look at that, what was the issue, which was overuse of antibiotics many a times rather than correct use that led to the problem. And then when we fall sick, we don't have a pipeline. So at that, rather than reflect at that point, the idea of the antimicrobial awareness week and to create awareness is that we make everybody aware of what the problem is, and so that they themselves can advocate and educate about the problem to their own smaller circle of influence. Now, this circle of influence for us means, first of all, awareness and education in the common man. So, demedicalizing the problem and taking it to the level of a person that if you have antibiotics on your own without checking with a doctor or a diagnostic test, you are in for trouble, because which a trouble that will lead to not just your health being at risk, but the risk health of all of those near and dear ones around you, which will be at risk. So awareness that will help people understand this issue is critical. That is one. And this awareness does not have to be very high end messages. In our day to day behavior and societal circles, what we see about how healthcare is accessed by children, men, women, how the biases that we have in our socio-cultural and behavioral systems reflect the healthcare seeking behavior that people have. So rather than thinking of a shortcut of not going to a doctor, for example, for a woman of the house, that I would have to not cook one day, prevent that means having problems for my kids or my husband or my family, I'd rather take an antibiotic and continue to work. Now, that is the area, for example, that we need to educate women on. So, women's education becomes important. Similarly, working people, when they want to avoid one day of work, just by popping a pill, they can continue to attend their day-to-day work, and then later on have a more severe infection, not just for themselves, but their house, their workplace, etc. So that is one. But in addition to that, education is important for also all our one health professionals. So in the human health sector, for example, we have doctors, but it is not just doctors who are in the system that they only prescribe antibiotics. There are pharmacists who dispense antibiotics. There's a nurse who actually makes sure that the antibiotic is given to the patient. There's a patient and their caregiver who makes sure that the antibiotic goes on time. Similarly, in the animal sector, the vet, the paravet, the farmer himself. So, this just gives us an assessment of the dimensions of education that we need to have. So, involving these professionals, having continuous medical education programs for them, and basically taking the message that resistance is fatal if antibiotics are not used as provided. Remember, these are tools. If they're used for firefighting, they will stop being effective in the long run. So such messages in which we involve the community, taking this message to our, for example, in the village and health nutrition day, in the cities, to the residents welfare associations that we have, where so many elderly actually sit together and talk of the times when we used to just take the antibiotic and continue our work. Those are examples we need to cut down, and helping prescribers and healthcare workers have tools that can diagnose an infection. And we call them point of care tests, so that the doctor can actually, or even in many places trials are done with pharmacists or dispensers who can just do a dipstick test the way we do a pregnancy test, to show that, see, it's a viral infection, doesn't need an antibiotic, just go home, rest, have fluids. That helps, because people have that tendency to look for some placebo or some way that makes them feel taken care of. And that could be just a hot fluid alternative, like Rajeshwari was mentioning, that has been passed on through generations but does not need to be an antibiotic. So I think involvement of community and healthcare providers is critical in these very ways. And just to summarize, like Tikesh was mentioning, even in the National Action Plan and all the antibiotic awareness weeks that have been done, the government through the national and the state level is trying to do that. But considering the size and scale and breadth of India, it's not enough. Like we've seen a revolution with children being involved in the seat belt campaign. I think that is the kind of awareness we need in the country to make sure that antibiotics are not taken by anyone just because they feel like it, rather only when a doctor has prescribed and it has been defined by a diagnostic test. Thank you.
Right. So my next question is for Dr. Rajeshwari, that how can policy harmonization across healthcare and agriculture improve AMR mitigation efforts in India?
Okay, thank you for the question. So I have, when I was reflecting on the question, I thought about responding it a bit differently. One is we have been talking about the need for harmonizing policies, having a uniform approach to addressing this AMR issue. It's a One Health issue, but what we also think is that it is time to also realize that each and every sector, for example, the agriculture sector, the food sector, the environment sector, the human health sector, the problems of each and every sector is different. So it is not very easy that we always say that a harmonized policy can address all the problems. So on one hand, yes, interconnectedness between what we are talking is important. It is important to link solutions. It is important to draw from each other's examples. It is also important to have harmonized policies, but I would say that is not the solution all the time. But having said that, I'd like to stress on 2 points, largely from the food animal production sector, because the CSE's body of work has been on the non-human side of the AMR problem. One very important point I would like to stress is that antibiotics are still being used as antibiotic growth promoters in the food animal production. There is a ban on colistin, and some other developments have recently happened with an FSSAI notification in the last month. But when it comes to the use of critically important antibiotics, we have doctors on this panel who have already stressed on how important it is to conserve antibiotics that are being used in humans. I think it's very important that we harmonize and we start looking at what antibiotics are used in humans and how they can be conserved and not used in animals, because we have seen from our work on the ground that there is overlap in the kind of antibiotics that are being used in both sectors. So there is a kind of discussion that needs to happen on and at the global level there is some movement, there is some progress on it, but at the country level also we need to come down to think of that. The second point I want to raise is on surveillance. Again, surveillance is something which we are talking about. Again, it's a sectoral. Human health will be doing their own surveillance. Infar network has been mentioned. They just released their data earlier this year on surveillance in livestock and aquaculture. But what is important is we draw from these informations instead of saying that the surveillance in this sector has very less resistance, so we are not the problem. Surveillance in so and so sector has more resistance, so they are the problem. I think that should go away, that should be done away with, and instead we should put down our brains to go and see where is the problem and how can we draw from what we are getting from the surveillance data. So when it comes to harmonization of policies, I think we need to dig down a bit more rather than saying that we need a uniform policy or we need a streamlined policy, because it is the responsibility of each and every sector to clean up their own houses first before we talk about interconnectedness, before we talk about coming together and addressing this One Health problem in a One Health manner. Yes, it is important, but it's also important that we first look at how we address our own sectoral issues. I'd stop there.
Right. So intersectoral policies are definitely important, but definitely we have to address our issues and our sectors first. Well said. My next question is for Dr. Vasant, that what are the key strategies clinicians can adopt to minimize the overuse and misuse of antibiotics in treating infections?
Thanks, Dr. Manisha, for that very, very important question. Uh, what can the clinicians do to restrict antibiotics? I think in the tertiary care centers, it has to be diagnostics. I think if you have good diagnostics, then it will definitely be useful. Even let me start from community acquired levels. I think the family physicians and the even the physicians, if you see 80 to 90% of the illnesses in the community are more of viral illnesses, whether it's viral URTIs, whether it's H3N2, or whether it is H1N1, or whether it is any of the viral illnesses apart from dengue, chikungunya. So many of these, none of them actually require any antibiotics. So I think the first thing is to restrict usage of antibiotics at the community level. So when I'm practicing in my clinic, I hardly remember writing a prescription for antibiotics unless it's a definitive urosepsis or a proven typhoid fever. Otherwise, for URTs and all that, I don't think you require to use antibiotics. And antibiotics of high end being used at a general practice level where they're using even injectables and drugs like linezolid and all that, which are very, very important for India as an anti-tuberculosis treatment. So I think the first thing is to restrict usage of, I think, more and more education for the family physician levels and for the physicians, that antibiotics is not everything and it's not needed to treat each and every patient, because I think 80 to 90% of the illnesses which come to the general practice or family physician practice level is viral. And the same is the true in the Western world, but I think at least there you have some rapid tests in the clinic where you do some rapid test and then you get a quick diagnosis, and to some extent the restriction. But there also I think 50-60% of the prescriptions are because of misuse of antibiotics at a community acquired level. So that is one thing. Second thing is, I think, second, when it comes to a tertiary care center, how can we restrict usage of antibiotics? So I think very important would be to any patient who comes to you in the hospital, if you have quick and fast diagnostics, you can definitely restrict the usage of of high-end antibiotics. Like your first, very important is to distinguish whether it's a community-acquired sepsis or a hospital-acquired sepsis. And if it's a community-acquired sepsis, then you don't require very high-end antibiotics. At the same time, if you have tests, and I think in the last 5 years we have really moved ahead in terms of diagnostics. At least even if you have started, say some patient is in septic shock and you have started a carbapenem or a high end antibiotic, because of the rapid diagnostics which have been in last 5 years, has been a real game changer actually in utilizing or optimizing your treatment in some of the major tertiary care centers. The problem is, I think, education at primary and secondary health care centers. For example, I think I will give you that, with the patient who is coming to sepsis, and your blood, you send blood cultures and your blood cultures come positive. Earlier days, say 5 to 10 years back, we had to wait at least 48 to 72 hours to identify the organism and to get the sensitivity. Now with the rapid blood culture identification systems, you once your blood culture is positive, you can get the answer within less than 2 hours, what is the organism and what is the mechanism of resistance of that pathogen also. So quickly you can, suppose if you have started with a high antibiotic, you can come down or de-escalate the antibiotic quickly. That is very, very important. Similarly, a lot of these respiratory biofires or pneumonia panels, joint infection panels, the meningitis panels. So all these rapid diagnostic checks have been a major game changer in, I would say, last 5 to 7 years in the clinical practice at a tertiary care center, where you may have to de-escalate or possibly escalate also. So using the correct antibiotic is not only de-escalation, but sometimes escalation also to treat the patient correctly is also very, very important. So I think, but what we require is much more better tools of diagnostics for a rapid diagnosis at a bedside level. I think there is one the recently which won the award in UK. I think bedside urine test. I don't remember the name, but rapid test bedside, where a clinician can use it in the OPD. It's just like a pregnancy test. You come to know quickly what is the organism and what is the mechanism of resistance. So you don't have to use again high-end antibiotics. Similarly, if you have these type of tests directly getting it from the blood sample, what presently we do is we send blood culture bottles, the blood culture bottles flags, and then we have the organism to be subjected to a rapid test. But even suppose if you have tests in bedside, and I know that when I'd been to ID Week this time at Los Angeles, we saw that many of these companies have come forward to detection of organism directly from the blood sample. Just bedside, you patients come in septic shock, you collect the blood immediately, subject it into a machine, and possibly it may give an answer. But I think it's still a long way to go. It is too early, and the results are preliminary. But we in future, I'm sure in next 4 to 5 years, we'll be having all these bedside tests, and we will be able to justify our treatment for in the hospital. Apart from that, I think having a very strong antibiotic policy, not only having a policy, but all the clinicians following the policy is very, very important. And I think at a national level, possibly something like an app which should be developed for all the clinicians, and it should be universal. So with people to for all the clinicians to have a guide as what treatment has to be initiated for that patient. I think I would say the only way to tackle resistance and to utilize your antibiotics is to have good diagnostics, rapid diagnostics at a cheaper rate, not having diagnostics at a very costly rate, but to have it at a much cheaper rate. And I think we are using this in the tertiary care centers, private centers, but I think the same has to be utilized in the government sectors and municipal sectors, so that you can you justify your usage of antibiotics there as well. So I think diagnostics is the way to go forward. I strongly believe in that because that gives you the way forward to your treatment part for the patient.
Right. So, diagnostic for de escalating or escalating the antibiotics to save lives and also to combat AMR. So, my next question is for Dr. Tikesh that how effective has the AMR surveillance network been in monitoring and reporting resistance trends in India?
Thank you, Dr. Manisha. I think this is a very difficult question to answer, but I will try to be precise and brief. As in previously, I mentioned that in India there are three major surveillance network. One is NARSnet implemented by NCDC. Second is ICMR based AMR surveillance network, and third is related to veterinary, poultry, and aquaculture, that is Infarnet. Would like to highlight that these are a surveillance network after launch of NAPCOR has grown exponentially, and at present the majority of the sites in all the surveillance network are the tertiary hospitals. So if we talk about the NARSNet, so recent report has been released of NARSNet and the period is January to December 2023. They are focusing on nine priority pathogens. The and again In that report, 41 sentinel sites has been mentioned, and if you see the current status, I think there are 50 sentinel sites, and the report which says in last year there are 1,51,000 isolate were reported, and in that E. coli continued to be a majority priority pathogen, that is 34%. Also, it shows that resistance pattern has notable means increase in carbapenem, that is 40% E. coli and 54% Klebsiella. Also, there is a clear indication that gradual increase in vancomycin resistant, also extended spectrum beta lactamase. And among this isolate, there are 53% will be from inpatient, and urine sample represent a high proportion of isolate, that is 46%. So this is related to the NARSNet. If we talk about the ICMR network, so this ICMR network is operating since 2013. Again, this is a major surveillance network and focusing towards tertiary care hospitals. And if we analyze last year report, which is recently released, again that's last 1 year, so it is based on approx 99,500 culture positive isolates. Again, it is mentioned that E. coli the most commonly isolate pathogens. The Klebsiella pneumonia exhibit a significant drop in susceptibility to carbapenem from 58.5% in 2017 to 35.6% in 2023. But Pseudomonas showed concerning trends, increasing from 26%, which was in 2017, to 38.5% in 2023. Even also, there are not notable findings related to the whole genome sequencing that indicate that NDM1 gene in E. coli 34% and SHV in Klebsiella pneumoniae, that is 50%. So it underscores that there is a increasing threat related to carbapenem resistant pathogen. And if we talk about the third major network, it is again Indian Network for Fishery and Agriculture for AMR. So at present, they are collecting samples from 28 districts spread across 7 states, and it has very interesting findings related to that Staphylococcus aureus showed high resistance to penicillin 91.3%, erythromycin 36%. And in freshwater fish, ciprofloxacin resistance was particularly high, that is 54.8%. And if we talk about the E. coli resistant, which is to critical antibiotic like imipenem or ceftriaxone, it's comparatively low, but it has increase in marine fish isolates. Also, if we see the resistant to cefotaxime and cefotaxine was particularly concerning because almost 67% in cefotaxime and 54% in cefotaxime. And this is about a quick summary of this three network. I would like to highlight that respective state also come up with their state level surveillance network, like in Maharashtra Mahasar, in Kerala there is Kelsar, and in Delhi there are Delsar. So all these network are uh, contributing to this national level surveillance network. And just to ensure that this all this data collected from this network need to be aligned, so there is a quality assurance mechanism also. So there is an internal quality assurance mechanism, external quality assurance mechanism, and addition to that, these are complying to the international standard also, clinical laboratory standard, also UCOST, means European Committee of Antimicrobial Susceptibility Testing. So they are uh, complying with this international standard also. And at present, just to maintain the data quality, the means not across all, but they are using the WhoNet platform. And I would like to emphasize that still we are receiving these the network are not, we cannot say consider as a sample representative for across the nation, because as previous speaker also mentioned that India is a diverse country and there are multiple geographies and the resistant pattern vary from geography to geography, right? So there is a need to increase this network, and at present we are focusing on tertiary care hospitals. Still community based surveillance is a need to be incorporated, though there are wastewater surveillance, but again it's limited to a small geography. So there is a huge scope for expansion of this surveillance network. I will take a pause here. Thank you.
So, my next question is for Dr. Jyoti. What are the main challenges in developing affordable and accessible diagnostic tools for low and middle income countries to combat AMR?
Well, that is the key question, I would say, in today's times, as we need to diagnose AMR infections earlier. The challenge, like Dr. Vasant was earlier explaining, is these diagnostics require, in a lot of investment in research and development, because these are to be tailored depending on the specifications, like whether they are to be at the point of care, at the community, pooled or individual based, etc., and what technologies they use. There are a lot of diagnostics available even today, like he mentioned, in tertiary care hospitals, but they are very expensive. So having these diagnostics which are affordable, I think, is the first challenge. And having developers who work on these diagnostics know the problems that are faced in the real world solution to develop that target product profile of such tests is the other challenge. There are post-COVID, we have seen that when required, the world can come together and develop diagnostics in a short period of time, but we need resources. That means people, first of all, who are working on that area, whether it's at the bench or in the hospital side, to do those, to use those diagnostics, and then to standardize them and develop them for different contexts. So developers, I mean, AMR, antimicrobial resistance, I must say, overall is a field which in the field of research and development has the least profitability for many companies, and thus many of them are moving to better pastures, if I can say, greener pastures, which are more productive, whether it is in the today's non-communicable disease epidemic of obesity, hypertension, cancer. A lot of research focus, which is in the developers or the companies that develop diagnostics, whether they're large firms or small bioinnovators, is on those areas. But all of these areas, whether it's non-communicable disease or hypertension, also require antibiotic use. And thus, this is an area which is being incentivized by governments all across the world, including India. The different fora that can, it also requires a lot of interdisciplinary research. That means the people who work on the bench side in the lab need to have an understanding of what are the challenges, and they need to have the access to the samples of resistance of patient samples, patient challenges, etc., the clinician challenges, so that they can wrap their brains around and come up with possible solutions that work in a particular context. And we have seen a lot of whole genome sequencing, and resistance is transferred through genes amongst the bacteria. And like I was telling in the middle earlier, it can be transferred from one bacteria to another, but from a good bacteria to a bad bacteria to a good bacteria also, and just make it resistant. So learning this concept that finding the gene, does that equal resistance or infection, or finding the infection, does that equal to symptoms, and then finding the symptoms, does it mean you require treatment? These are the steps that a diagnostic test need to pass so that they can inform the doctor or the user, whoever it is, whether it's a patient like in the pregnancy test, to enable them. There are these challenges now with the poor pipeline, less number of researchers working on it, and the profitability margin that this such tests can get. So the incentives that the governments are planning are ranging from push and pull incentives that companies are announcing so that they can pull the best of minds to do such tests. The other part, which is unknown, I think, in that sense, is the standardization of such tests. We also have a flood of tests available in the market that are available but may not be of the best quality. So you and I would rely on a particular test, but unless it's accredited, it's done standardized, it's up to the mark that is the cutoff for infection and not just presence, is the challenge that a clinician has when he or she relies on such tools. In addition, now I think the other challenge is remote. I mean, the opportunity also and could be a challenge is remote areas where people may not have access to the diagnostic but need the result. So there are a lot of remote sensing abilities where, for example, the samples are the OCR, the QR codes that we use for payments are also being used for making decisions based on the samples on those, the results of probably, let's say, a blot test or an ink test like we used to have. But that also requires a lot of interdisciplinary research where researchers who work on such platforms can work together with clinicians, with common man, with lab scientists, etc., to understand how the available technologies can be repurposed and reused for such processes. There is also a lot of excitement. I mean, there are a lot of challenges. Your question was about challenges, but maybe the only note I would like to end on is there are a lot of positive options that are emerging as opportunities, and COVID for me is an exemplar. So even during conflict situations or crisis situations, there are a lot of tests that are being used and are being repurposed for diagnosing without having a skilled workforce at that particular place. So keep watching, and I think this is the area that will show a lot of results in the future.
And we definitely need affordable and accessible diagnostic tools in a country like India. My last question would be to Dr. Rajeshwari. What should be the top policy priorities for India to achieve sustainable progress in combating AMR?
I think at this point of time, sitting here, the top policy priority very clearly is, we should be looking forward to having the National Action Plan version 2 in place. I think the National Action Plan 1 was from 2017 to 2021, and we are working and towards the second part, volume 2 of it. And I know that different sectors are working. This time the approach is very different. Different sectors are looking at their own kind of problems, the feasibility, the kind of resources they have, and how much they can do, what are the low hanging fruits, what can be done, not done. So every sector is working towards its own set of national action plan, and then everything will come together. So most important is that we have our action plan, and what is important after that is, once we have the plan in place, how do we take it forward, is to have whether we make long term goals, whether we make short term goals, and how do we take it forward. Given the kind of work that we do on AMR, I think from the policy point of view, what we would really push for is to look at considering restricting the antibiotic use as growth promoters. And very importantly, which I have not mentioned, is that their use as their use in disease prevention, which is not real prevention. We are using in food animal production, there are antibiotics which are used as an easy economic substitute, to substitute for the farm setting, for the unsanitary conditions, or for the kind of climate or the weather that we have, or the high stocking density which can lead to diseases. So the non-therapeutic aspect of antibiotic use is something which really deserves attention, and it's not just the growth promoter use which we have been talking about. The other kind of policy attention that we would call for, and there has been some movement around this, is that looking to conserve critically important antibiotics from the point of view for human health, and conserving them from the food animal production. I should not say that these antibiotics should not be used in food animal production under appropriate veterinary supervision. This must be used. This needs to be used in order to save the animal. But when it comes to the non-therapeutic part, there are other ways to handle the problem rather than using antibiotic as a solution. I think that's where I would like to end. But I also want to mention that whatever I have said, I understand it's easier said than done. It takes time. It takes a lot of thinking. It takes a lot of people to come together to bringing to the ground and taking action on it. So we recognize and we understand that it's not easy, but we also know that this needs attention, and this needs to be taken forward. Yeah.
Right. So, as we conclude the session, it is definitely clear that for combating AMR, we require collective action, innovation, commitment. We need to align policies. We need to have accessible and affordable diagnostic tools, and we need to have, collaboration. And we should embrace the sustainable practices in India. And let's continue to work together to safeguard public health, agriculture, and our shared future. Thank you all for your participation.
Thank you so much. It was a pleasure meeting all of you and being a part of the program. Thank you, Dr. Manisha.
Thank you.
Thank you. Thanks a lot.
Thank you.
Thank you.